second. And now I'm just going to keep adding people. And Mitch,
Mhm.
can you please just chat with the people about what the format is, and then they can, if they have question, maybe they can ask in the chat question first, and then we can bring it on. So, so good morning. This is Essence of Medicine. This is our rapid podcast with a very short notice, and I'm very happy that we have few people who are going to join us. I just finished a transkambin OLLIF 3 level for this case, which I'm going to share the screen and show what that case is. And we have a few people online with us. Mitch, why don't you introduce yourself? And then I'd like Dr. Okumu as well introduce himself. Mitch, who are you and what qualifies you to even talk in this podcast?
Sure. Well, obviously, so my name is Mitchell Rustin. I've been working with Dr. Abbasi for, 5.5 years or so. I've been in your OR. Not only been in the OR, but I've roomed some of your patients. I've done a number of things with you. So I've been fortunate to see a lot of patients, end to end before the procedure, during and after. And obviously I was a part of this one today. So I saw it live. So I'm here to give some commentary.
And as well, you have been crucial in actually training a lot of surgeons. When we do a lab, 9 out of 10 times you are there and you're an active part of this education, correct?
Yes, sir.
And then we have Dr. Okumu. Thank you joining our podcast. Do you want to tell a few words about yourself, your practice?
Sure, thanks. My voice is a little, I'm a little under the weather, so my voice is a little odd today. But my name's Chris Okumu. I'm orthopedics fellowship trained in spine. I first got introduced to the kambin triangle after I'd been in practice for a couple of years because it wasn't something that was really taught in orthopedic residency. I don't even remember it from my fellowship, but it was a very intriguing approach. It was frightening as hell because I didn't understand the anatomy. But once I began to do it, I realized it opened up a bunch of possibilities. True minimally invasive surgery. Used it quite successfully, and it's expanded the patients I can offer this to.
Where do you practice, Dr. Okumu?
I'm in Santa Cruz County, California. I was in private practice in San Francisco Bay Area, but I'm in Santa Cruz County.
Now, you mentioned few things. Number one, you didn't learn it in the residency. Number two, you mentioned the word frightening. I think that's a very good choice of word, actually. Yeah, do you want to elaborate a little on that? What aspect of this practice was frightening at the beginning? And I think good surgeon, like yourself, they should be frightened every time you start something new. But do you want to elaborate on that?
Certainly, yeah. So I've been fortunate in my career to have been able to work closely with neurosurgeons since I finished my training. So I believe I was about 4 years out of training when I went to private practice in the Silicon Valley. And I shared office space with somebody who's a close friend now. He's a neurosurgeon at Stanford. And I said, "Have you ever tried the transkambin approach?" Yeah, I don't think he called it transkambin. I think that's Dr. Abbasi has correctly given it that name. Some credit where credit is due in honor of Dr. Kambin. But he mentioned an interbody fusion being done through Kambin's triangle. And I looked at the results and watched him do a few cases. It was terrifying because you don't know that it's not anatomy you're familiar with. Like anytime you're doing, I'm not sure if maybe there are surgeons who are not afraid of anything when they've seen it for the first time, but I certainly am. And it's not terror; it's just concern to make sure you understand what you're looking at so you don't harm a patient.
And that's a hallmark of a good surgeon, to be cautious and have heightened, alertness when we do anything new.
Exactly. Yeah. So I watched him do a few, and then he had me do a cases with him, and I started doing the approach, and it's served me well.
Well, why weren't you afraid or frightened when you do TLIF? Why weren't you? I think that's core of it is so simple. Why were you not, when you went to practice surgery and spine, when you did your first 10, 20 TLIF, I'm sure at the beginning it's a little exciting and so on, but you weren't really frightened, I'm assuming. So why weren't you frightened with TLIF, but you were frightened with OLLIF?
Oh, well, again, it's familiarity, right? So TLIF is something that's taught well in residencies now, but back in my residency, maybe not everybody was doing TLIFs. So it's familiarity with it. And the first 10 or 20 that I did out in private practice, I'd already had the experience of doing it with attendings and with fellows and learn from other people. There's still a little bit of nervousness, of course, like anything else, but yes.
Over what period of time did you learn that TLIF?
Oh God.
Oh God, exactly.
You learn it, but you still it doesn't become facile until you're in practice doing it yourself.
Yes, that's true.
And that's why I said that nervousness is there. They always rule about 5 years before a surgeon completely becomes comfortable with his skills. That's all true. But at the same token, the neurosurgeons I worked with were terrified of the osteotomes when we were doing deformity cases.
And you're absolutely right.
With anatomy and instruments.
Absolutely right.
Yeah.
And as a matter of fact, I, as a neurosurgeon, I learned to drill the facet layer by layer. And my colleague, Dr. Kim, he takes the osteotome, tap, 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 something that I used to do in 15 minutes. He used to do in 15 seconds. And but you're absolutely right. No, I think you learned the TLIF over years. You didn't go to a weekend course in Vegas or did a cadaver lab and came back doing TLIF. I think that this similar familiarity comes from being exposed to that over a period of time. And as you said, we did not learn transcambin approaches in the residency. But the surprising part is that the transcambin approach have been existed actually longer than TLIF. I mean, the TLIF by Harm really literally came to existence in the 1980s, whereas Dr. Kambin, a few years before TLIF, described the Kambin triangle and endoscopy in that area. And unfortunately, TLIF caught up, but the transcambin approach, they did not caught up. They went to Asia. For that reason, endoscopy really was a big deal in Korea, Japan, China. And just in the last 20 years, we are re-importing back that. The sad part of it is Dr. Kambin was practicing in Philadelphia, not in Asia. Now, by the way, Dr. Parviz Kambin is a Persian guy who actually finished his school in University of Tehran, moved to United States. And I talked to him 9 months before he died. He used the endoscope and of his urologist friend, and he could see. And that is how he described it with his paper. But officially, that was done before TLIF, and that is the sad part. Now, practically, he told me that he used it for decompression, but he couldn't imagine that we can do fusion. But now, obviously, we do fusion. I myself alone I'm getting close to 1,700 cases, and this is my case from today. And I think the hallmark of transcambin approach, I want to talk about this case. Please ask questions. And then based on this case, I want to demonstrate why between 2011 and 2014, 500 people were trained, but less than 5% of the people continue doing that. And I think what you learn from this picture, Mitch, is the picture coming out, what I'm sharing of our cases today?
Yep, I can see it just fine.
Okay.
Yeah, I can see it.
Hallmark of this is do not start with this case. That's what it is. And one of the other hallmarks that we have noticed is that we have trained probably over 200 surgeons, and univariately we see them in two categories. Surgeons who come and look at it and they're taking a step back. Oh, what happened? This is impossible. I don't believe I can do that. And then we have surgeon who comes and say, oh, that's easy. I think I can do that. Now, we keep track of their performance. Mitch, what have we observed in observing their learning curve? Because we have made the science of the learning curve of all the surgeons. What have we seen in our study of their learning curve?
Well, obviously, people do a lot better once they have, proctorship. You have the soft transition protocol that you employ. So not only is it, a cadaver lab or something, you get one chance to be familiar with it, but usually we would prefer that you have a proctored surgeon in there with you. And usually most people, they kind of hit a core level of competency around 20 to 40 cases.
But we have noticed as well that people who come and say it's easy, I can do that, their learning curve is twice as long.
Yeah, they do when it goes bad and then they never touch it again. Yeah.
So my hat off to you, Dr. Okumo. I think you are in the category of people who say, I'm frightened. What's going on? Can I really do that? What do I need? And this has been as well proven across any kind of teaching and learning. We call that the so-called Dunning-Kruger effect. People who get confident too fast, most of the time they don't have the fundamental knowledge base to really back it up. Now, Dr. Okumo, this patient has, and as well to the rest of the team that are here, I'm going to show you actual pictures of this. This patient has severe back pain, has a radiculopathy on both sides that correspond to anterolateral thigh. And in this case, patient is not the youngest patient and has some comorbidities. So we decided to do a segmental correction. Now, I just want to as well emphasize that there are multiple different ways of doing the surgery. Dr. Okumo, that in your today's practice, if you needed to correct this patient's deformity with proper symptoms and as well long history of non-surgical treatment, how would you treat this specific patient? I think Dr. Okumo is muted.
Oh, sorry, you didn't.
Okay.
There you are.
Sorry, I had the sorry, I didn't have the microphone
Don't
on.
worry.
Yeah, I haven't seen the sagittal, and without knowing a little bit more about the patient, I fell off for a second there. But most people would think about doing, lateral interbodies for this patient if they're doing those procedures. But obviously, you can't do a lateral L5S1. You can do the obliques, transpsoas. But this would be a case that would be amenable to transkambin, I believe.
Yeah, it is. We just did this surgery now. But I think I apologize. I didn't take a picture of the sagittal, but sagittal deformity is not really prominent. I think the sagittal balance more or less is okay. But now this is a case I told you I'm not going to start with this case. And the problem is the setup in the OR is quite significant. I'm going to go through that. What really scares me from this case is this. Patient has a torsional abnormality of the vertebral body. And that adds a lot more consideration to how the surgery done. I did I asked about 30 to 35 surgeons who quit doing OLLIF in 2013, 2014. Almost all of them that quit, they quit between case 5 and 7. And that was the time that they saw their first patient back. And as well, they hit the ground, they had the initial success, but then many of these patients, sometimes 50% came back with nerve root irritation. And one of the hallmarks is that, and that as well happened to me, that we get comfortable quickly and then we progress too fast. Like one of my permanent nerve damage was my 4th patient where I decided I should do a 3-level OLLIF. And that is a patient that has still to this day had the worst result regarding nerve damage, neuropraxia, and so on. And I think after I thought I'm really good at it, I took on doing too much too fast. Now, after that was a waking up call for me. After that, I waited another 100 cases before I did a multi-level, 3-level fusion, and that patient had some scoliosis, and waited another 400 cases before I started doing, I think that was the wake-up call for me, and that again awakened my heightened sensory that this is not what you're familiar with. Don't jump too fast to this. Now, in this case, this is a true AP. Now, this patient, in this picture, the machine is a true AP to patient. But everybody here, I hope you understand, this is not a true radiographical AP of the patient. So, meaning that in this case, we need to do segmental adjustment, make this picture to this picture. Literally, if you look at that here, this is a position of the C-arm that resulted in this picture. And now, this is the position, it doesn't really come out that well, but hey, really you have to do some acrobatic, and you have to do segmental. And there are lots of subtleties here that is really contribute to have a good AP and lateral pictures. Now, initially as well, some of the doctors used the endoscope. Dr. Gumo, did you ever use the endoscope with your transcambin approaches?
Yeah, actually, I clicked on for a second. Yes, actually, Dr. Said Usman is a person. I went to visit him in Frederick, Maryland, and learned the endoscopic. That's where I really learned about kambins. But yeah, I have used the endoscope.
No, I used as well for a few dozen cases. I did use the endoscope initially, and then I quit doing that because I noticed that with the true AP and lateral, if you get a good true AP and lateral and good neuromonitoring, the endoscope wasn't really adding much to my practice. Certainly in India, now a lot of people are doing a transcambin approach, and not all of them have access to neuromonitoring, and some of them literally visualize the approach to make sure they are not putting too much pressure on it before they enter the disc. But if you have a good neuromonitoring, lots of our doctors now do this, not all right visualization with the endoscope. Now, I'm just going to...
So I misunderstood you, Hamid. So yeah, I never used the endoscope for direct visualization. I use it for other cases. But you're right, with the neuromonitoring, if you understand your anatomy, and again, starting off with the easy cases, like you've said, build your experience up before you more the complex ones. I think the endoscope doesn't add anything really.
Totally agree with you. But in India, the neuromonitoring is something that adds cost and is not always available. So Dr. Varun Agrawal, a good friend of mine, actually is doing these cases with awake. So because patient is awake, that is the neuromonitoring part. And in some other instances, they use an endoscope. By the way, if you look up OLLIF, the word OLLIF, Google will tell you a full endoscopic transcambin fusion should be called OLLIF, which I agree, because that is how Dr. Kambin described kambin triangle endoscopy. But the version of the transcambin fusion that is not endoscopic, we did with true C-arm and with neuromonitoring, that is what we call oblique lateral posterior lumbar interbody fusion. So practically, we get a true AP lateral, and that is the point. You have to adjust it segmentally. Each segment, if you go back to this picture, the spinal process is not equidistance. Then obviously this would be the approach, the discogram or nerve root injection, but this is not a good approach, transcambin approach. Whereas once you adjust it, then you can get a good approach. Now, it doesn't come out really, but we have a scoliosis here. As you see in the initial picture again, quite significant scoliosis. By the way, this is the CAT scan, meaning patient is laying down. Obviously, when patient stands up, the scoliosis gets even worse. So, move on. This is one of the things I'm really proud of. Look at what you see on the table. This is the table for the interbody part. On this table is everything you need to do transcambin OLLIF. You don't need $1 million C-arm You don't need a $5 million robot. You don't need an expensive, retractor system like from laterals. Everything that you need to do interbody fusion with OLLIF is on the table. Now, this is the line that we draw, and it doesn't come out, but patient had after first layer of correction is actually when patient is prone. We use patient's body to correct as much of scoliosis as we can. And then lines, you see that, and then again, it doesn't come out quite well, but machines are in a very awkward position to get a true APN lateral of that level. This is the setup that came up after 200 cases to enable us to move the two machines in a way that they are not in each other's way. And I think after interviewing many people who quit, they were extremely concerned that these machines, they were in each other's way. They couldn't get a good picture because they couldn't position the machines to give them a good APN lateral at the same time. And guess what? It took me 180 cases, and any position of the two C-arm that you can imagine I tried before I came up with this. Now, I have the feeling when we start doing something after the residency, most of the time we go to a course, we go to a very short observation, we come back, and unfortunately, everybody try to repeat his own learning curve, rather than when we go to a residency, we are adding to the learning curve of our many, many attendings. Like Dr. Kuma, I'm sure you're trained under a dozen or two attendings. You observe every single of them. They give you their learning curve and you add to that. Is that correct?
Oh, yeah. And not even just attendings. I learned from other surgeons who I've learned from a resident before. Yeah, you learn a tip from everybody. Yes.
Everybody. Whereas unfortunately, after the residency, most of the time we go to Vegas for a cadaver course. We do 4 hours cadaver course on 8 hours gambling and come back and try to repeat that kind of learning curve. And now the problem there is that everybody has to make his own learning curve, not like in a residency that you're literally benefiting from a long learning curve of number of people. And everybody who I interviewed, they went through the anxiety. If they were good doctors, they went through the anxiety. And some of them say, you know what, I'm so good at TLIF, it is not worth for me to go through the learning curve of OLLIF in this fashion. Now, a group of people kept doing that, and I was among them. And fewer number package their knowledge in a way that can be passed on to other surgeons, and that's what the sub-transition is. I just was telling to Mitch today that a tool is a tool, and certainly we have really refined the tool. What you see here, all to optimize that. But a fool with a tool is still a fool. So, and the idea is to be able to pass the knowledge that we use the instrument in a way that is really conducive to the learning. Now, I'm just through the pictures here. You see, fields look crowded. But you can take my word for it, but with this setup, which is the start of it, you have enough space. You don't need an assistant. Your assistant is actually on the back table helping you set up the instrument for you. And then I'm going to go now to the actual of the surgery. You see all the screws are placed. This is the end result. Give us this picture. As you see, the sagittal deformity wasn't really significant, but I think what's important here is the scoliosis is gone. And now I want to go to the pictures. And here is the AP. That first we put a K-wire, because we draw some bone marrow. Kuma, I think somebody in your background is talking. If you don't mind, thank you. Now,
sorry about that.
Don't worry. We put a chidi in, we draw bone marrow, not blood. From each level, we draw about 5 cc, and literally we mix it with our biologic that increases the rate of fusion. Here you see, if I go back here, let me see if I can go back. Here you see a neuromonitoring probe. It's placed in the kambin triangle, but what you need to see is, again, that is something I learned over 250 cases, that I freehand navigate through the kambin triangle. I always hit the vertical of the level below, and then I drop the neuromonitoring probe. It's insulated all the way to the tip, and then sleeves come in to keep the trajectory, and then the K-wire goes in, and then over the K-wire, then we dilate. Then here you will see that in all these cases, I'm putting the cage the other side. And this eccentric placement of the cage is crucial, as you see here, to correct the deformity. And that is another reason when eventually everybody who is doing this surgery will hit a plateau, hit a brick wall. The cage, initially, your instrument, your dilator, they want to go where they want to go. It will take, I would say, probably 200 cases to 250 cases if you do it alone, or 50 cases if you do it in a soft transition with the two proctoring, so you can truly decide where do you want to put the cage, and your cage will end up there. This is not a trivial thing, and I have the feeling that many people who gave up on this because they thought they have no control where the cage was going to end up. In how many cases in my learning curve, the cage was very eccentric, and I just had to accept that, and I wasn't satisfied with that. But here, it's not by chance that the cage is eccentric. And when I'm moving, now let's look at views. And you see here again, we go through the steps. I'm entering, and I literally put the cage where I need to put it. I put the anterior orthosis, I put it to the other side to correct the scoliosis. This that you're able to see here enable me to navigate. Now, I published few papers that I had to gather my own learning curve. Like there's a method of prone-lateral that we do where we go superior to the nerve. We published a paper about that in 2017, 2018. That the combination of the variation of this approach enable us truly start in a place, take a trajectory that enable us to end up where we really want to end up. And that was lots of sorts of frustration for people who quit doing that because they thought they're powerless. This cage is going to end up. It is not so. But again, it takes about 250 to 300 cases for me to really be able to do that.
Stop it.
And it took. Now I see Dr. Gasco is with us. Is that Jaime? Is this you?
Yes, it's me. Sorry about that.
Excellent. No. Listen, I'm really happy you're here because I'm one of the Dr. Gasco is one of our star OLLIF performers who does a grade 3 L5 spondylolisthesis under 1 hour. And there are few people who has achieved that level of proficiency. And what I was absolutely awestruck by Dr. Gasco is that he never hold back to ask me, Hamid, come back here. Let's go through some difficult cases. And we could package those knowledge, we pass it to him in such a efficient way. Literally, it took me 700 cases to do my true scoliosis, like this case. Dr. Gasco had been doing this since his 70s, so he needed 10 times less cases to do the things that I did after 700 cases. And that is because he added to my learning curve. He didn't need to repeat that. And what I was really awestruck is that he did not hesitate to call me back in to do another group of patients, next level of complexity. And if for anybody who's interested, we have a very nice presentation of Dr. Gasco and his grade 2 and 3 L5S1 spondylolisthesis. Coming back to this case, here this is the skin of this patient. These are individual incisions, they are not connected. Even though if they're close to each other, I never connect them. And this is the end result of this. Now that's a different case, I believe. Let me go back. I want to go back and show you again where we started and where we ended up on this case. Now, Jaime, I'm happy you're here, and I want you to give us. This is a podcast, and there are few people here. I don't know the level of proficiency of other people except Dr. Okumo. I know that, but I want you to tell me and tell us what was the difficulties you encountered, and what was how did you overcome those initial learning curve difficulties? Because let me tell you why I'm doing this podcast. Since my last visit in 2023 in India, there are about 30 surgeons are doing it, and now a lot more surgeons are doing it in India. Probably are approaching 100, 130 surgeons that now in India are trying to do trans-kambin approaches. Many of those surgeons will go through the same learning curve difficulties that surgeons in the United States went through, and they're going to hit a brick wall, they're going to hit a plateau, and this podcast is supposed to soften their impact, practically their experience. So, Jaime, tell us, when you started doing that, what was the difficulties? What was the pitfalls that you had to overcome?
I would say the first pitfall is the targeting with the nerve monitoring probe. So in my first few cases after you had been there, I would say the first time I was able to target, but it would take me numerous passes and I didn't quite understand what I was doing. It's interesting because you think you understand what the goal is, but it takes you a little bit longer to internalize it, right? So I would say targeting is number one. Once the targeting is done in normal or pseudo-normal anatomy, then it goes to the listhesis cases that are a little bit more complicated, or the L5S1 cases where you have to deal with the crest. And this is what I would tell the rest of the group is, number one is don't hesitate to ask questions to whomever has been your proctor in this venture, and go back to him and ask.
Have a proctor. First of all, for God's sake, have a proctor.
Right, have a proctor, and then ask questions. Right, so go back and discuss cases. Hey, I've got this case. This is the difficulty. But I would say what's interesting about every learning curve, and this has probably been the most unique learning curve in my professional career, I would say that there's a point where you face things that I had not seen with you intraoperatively, meaning I'm all alone, I'm by myself, a problem happens, and then somehow I need to get creative about it. And the magic thing about this is that if your foundation is correct, the foundation of the way you're learning is correct, I think your instinct guides you in the correct way. And moreover that, I think you need to know when you are able to stop. Meaning, if there's a point in the surgery where you think that L5S1, you cannot do it, and there's been in the 200 cases I've done, 2 L5S1s in multi-level cases where I was unable to access the L5S1 disc interspace. I would say that know your limitations, but believe in those first few cases where you have been proctored. Communicate with your proctor like I did with you, and then at some point you have to bite the bullet, and you have to do it on your own, and you're gonna face stuff like I faced stuff where I was not sure I was gonna be able to do the case, but I still went and did the case. And I think it takes a leap of faith. You have to believe in this technique blindly, almost. It's the only way to succeed is pure belief in the technique itself.
And go through the learning curve. Now, again, Hamid, you remember you and I met in 2016 once, and then at that time, you looked at that, you said, I'm not sure if I really want to adopt this. And then in 2018 or so, I think we revisited that, and lots of things were more refined by then. And as well, or what I think, what you just described, don't jump to difficult cases. And that is where the 6-7 level of top transition come from. That the first level is L1 to L5 straight cases. The level 2 is L5S1. The level 3 is grade 1 spondylolisthesis, and then it progresses to level 5 and 6, that is the scoliosis and torsion. Torsion is even more. And then obviously the last level is the thoracic cases. All stepwise. Don't jump through the steps and let your foundation build up.
And I would say to those that are beginning or are contemplating to begin this technique, to consider the fact that in order to become good at this, you cannot do just one case a month. You have to do an average, I would say, of a minimum between 5 to 10 every single month to at least be proficient at it. And the more cases you do, the more detail you will see, the more you will learn progressively. And it's just like learning endoscopy. The beginning is this huge ordeal. But I am fully convinced that if you just get started and keep going, and not stop, then anybody with decent state of mind and hands can become a proficient OLLIF surgeon.
Yep, I do completely agree with that. Now, unfortunately, they're calling me to go and do some procedures here. I have to go, but I think this has been extremely valuable for people who are just starting. Start at the level that is and increase the complexity step by step. Have a proctor, ask your proctor. And as well, when I was in India, I noticed that lots of people are just making copies based on the picture they see from our devices. They just make a copy of it. The copies that we had lots of problem, we went through 12, 13 revision before we ended up with our instrument set today. And I see all the mistakes that in India, I was there, they were showing me those devices. I saw all the mistakes. Now for that, now we are giving them free of charge all our drawings, every experience we have gathered. Don't make a cheap copy. Make the original. We give it to you. We don't want any money from you. Make the original, but as well, let us teach you how to use that original. As we talked about that, a fool with a tool still is a fool, but let us not only give you the devices, but as well the proper protocol to use that. For that reason, we have started this fellowship program in India in multiple centers. Join that, even if it's for a week or two. Let's benefit from the experience of other surgeons who are very proficient. And I think, come to our meetings. One of the things I think is important in our meeting, as Jaime can tell you, our teacher, Dr. Nata, used to say, if you haven't had any and every complication on the book, you haven't done it enough. So you will have complications, you will have difficult situations, but as well as it's an old saying, the average people learn from experience of the others, but the extraordinary people, they learn from the mistake. The average people learn from their own mistakes, but the extraordinary people learn from the mistake of others. So be in these meetings, learn from the things that I did wrong, so you don't have to do it wrong. And I think being active, and I think Jaime truly pointed it very beautifully, you cannot be good at it by doing one case a month. So I see we are now way into this, and unfortunately, all good things come to the end. But Dr. Okumo, if you have any other comment, I like everybody here to ask one question or comment, but I have to go very soon and perform procedure. So any comment on this, Dr. Kumo?
Yeah, certainly. I think the most important thing is what you're saying is to not just attend a course, get some mentorship, do some cases, and at some point, when you've done enough cases, trust your anatomy when the difficult situations arise. It's very easy to give up on this technique because it is very different the first time you see it, and certainly when the first time you're doing it alone. But if you stick with it, just like anything else, a well-trained spine surgeon is, you prepare for it, you practice, and you'll do fine, and be able to have a lot more patients.
And I hope you see my screen from our surgery today, a 3-level fusion then in this elderly patient that we did in 67 minutes. Don't expect to perform that level. I have done 1,700 of this. The time will come, the time you will get more efficient, the efficiency will come. It's not about the speed. Now, Mitch was in that surgery. Mitch, did you have a feeling that I'm speeding up the procedure or doing anything? I'm trying to be fast or anything? No, Mitch, you're muted. But I'm sure that everybody in the room can say that it was just the flow of the surgery. It wasn't sped up. It wasn't. We didn't try to be fast. But once you go through this learning curve and enough numbers, you will be very efficient at this. Okay, and this patient.
Ahmed, one
Yes.
comment before I leave. I would say the X-ray technician is as important as the surgeon almost, and also have the same team. The same team every time, same setup every time, same team every time, same communication every time.
Absolutely.
100% agree.
It's a whole team approach makes it possible. You have to teach your team as well, okay? So here, I apologize. We didn't ask many people questions, but this episode of Essence of Life about the trans-kambin OLLIF and pitfalls and learning curve is specifically for Indian colleagues that many of them are start doing this, and many of them will encounter this, to encourage them to be part of the team, keep going. Don't let your initial learning curve discourage you, but ask for help. We are here to help you. We have a setup, we have protocols that helps you. Please be part of this community in the Kambin Society, and let us help you in that endeavor. Well, thank you very much, everybody. And I'm hoping we will make this episode available to many people, but specifically to our Indian colleagues. And I appreciate as well Dr. Kumo, Dr. Thomas, Dr. Gasco participate in this. And thank you very much.
Pleasure. Thanks for the talk. Have a good day.